I want to use my time to focus on naloxone and the access to that. And I know you've talked about it a little bit already in session, but I want to do a deep dive, basically. And so I'm noticing that other countries, and obviously, look, we have very high levels of injury and death due to the use of drugs in this country. I am seeing other countries start to look at the regulation of that. So I want to start, I suppose, by asking, if I have not taken any drug and I take, it's a nasal spray, yes? Yeah, okay. If I take a shot of that, what happens to me?
So you've taken no drugs?
No.
Essentially nothing.
Nothing.
Yeah, so it's an extremely safe compound. So you asked if there's actually two types of products. There's both an injectable and a nasal product. The nasal product is currently reimbursed by the PCRS on the opioid substitution prescription. So it's currently, you can get it in that way.
So if I picked it up off the ground and I didn't know what it was and I snorted it,
yeah,
what would happen? Nothing.
I think a good way to explain this is that there's opioid agonists.
Yeah.
And antagonist. An agonist is something that's active. It does something active, like heroin. Suboxone is a partial agonist, but yes, it has a positive, so it does something to you in terms of it being a psychoactive substance. Naloxone is an antagonist. It does nothing.
Does nothing.
Except in the place where you've taken an agonist, it takes that off of the receptor in the brain, and that then the effect of the agonist is totally gone because it's the antagonist that's on the receptor in the brain.
So what would happen? Temporarily, okay. So is it fair to say that access to that type of treatment is hugely important when there has been, I'm not sure who wants to answer these questions, when there has been an overdose, when there has been an imbibing of drugs that you want to cease?
Okay, yeah. I will declare that I'm the independent chair for the Naloxone Advisory Group at the HSE.
Good to declare, yeah.
So from my perspective, the answer is yes. Availability has increased significantly in recent times with regard to some of the changes that we've brought in about how people are trained, how people access training, how community groups now can register with the HPRA.
Can I stop you there, though? My understanding from speaking to a GP recently is that if I let's say working in the drug sector as a youth worker or something like that, or if I know somebody who I think might go into overdose, I need to go to a GP and get a prescription for that person. If I then, no offence Mal, if I then meet Mal and he's in the middle of an overdose and I give him naloxone, I then have to go back to the GP and explain myself and get another prescription. It doesn't lend itself to an emergency situation, does it?
No.
For a drug that has absolutely no impact on somebody who takes it for no reason.
Correct, and that's where we'd have to go back to our IMB laws with regards having the drug taken off being a prescription-only drug.
So where are we with that?
Currently, I understand that one of the companies is going through a process within the EU to see if they can remove it off prescription status, that it will be available that somebody can walk in and access that product themselves without needing a prescription.
So is it your position that, or the position of the HSE, maybe you can't speak for them?
I can't speak for the HSE.
But is it that the position then that the hold-up is because of the EU complication?
No, the hold-up is to do with drug legislation, i.e. like normal
legislation, domestic or
medicines legislation, both domestically and EU.
Okay, because other EU countries have started to be more lax.
Correct.
So in France?
Both in the UK, in England, sorry, should I say, to break it out.
You're not in the EU anymore now. So.
Yeah, but in England, prior to their departure, they brought in where you could walk into a pharmacy and get it without prescription. So anyone could access it that way. Ideally, that's the way the product should be accessed. But there's a stepwise process which is beyond my scope, but it's within the territory of the Irish Medicines and the HPRA and organisations themselves, and the organisation who has the product licence on the market, because they have to stepwise through a certain process. In order
you all have seen the rollout of defibrillators in this country in the last 5 years. It's just totally new, and my partner is somebody who would need defibrillators, and it's very interesting to me to see the kind of rollout of this very expensive, not very expensive, but an expensive technology which is now on the roadside and you can access it. What is the reason that we're not pursuing a defibrillator style approach to naloxone?
Okay.
Particularly I represent Dublin 1.
Okay, I'm going to counter that by saying that definitively would be the way I would want as the independent chair of the naloxone group.
You can walk up to a machine on the street and say, give it to me. Okay.
But there are some initiatives, so speaking about your Dublin 1 region, so there is the peer group called Ishka, and they're working alongside our HSE clinic, so they're going into the clinic and they're training the patients, and they are distributing the naloxone to the patient, so the patient is getting one for themselves. And
but if I'm a family member of that patient, I need to sign something that says I'm a drug user. I can't have it in my back pocket just to give to them. Isn't that right?
Well, that is the next point. So you will then need to look at the risk of your patients to see in what context are they using and in what context do you need to have the training and the provision provided, most likely to a family member, because the drug-related deaths are telling here. So 70% of drug-related deaths are opioid-based, so that's where naloxone is very, very effective. And only 4 out of 10 die alone, so there's somebody present in the house or whatever.
Save them, probably.
Yeah. So there's 60%.
It seems a lot of jiggery-pokery and running around the place. That if we just deregulated it, that would take away a lot of that.
We fully recognise the excellent safety profile of naloxone, so we would be very supportive of any
deregulation
of removing prescription requirements. We see it as a very safe medication, much safer than many medicines that are available to buy or be purchased in the pharmacy, for example. So we would see removing the prescription requirements for naloxone as a good thing, and promoting the dispersion and availability of naloxone would be a priority for us.
Can I just do one really quick question? Because I'm under the impression that, let's say with nitazines now, they're so strong that you don't just need one nasal spray, you need 3, 4 to save somebody's life. Are you, as representative groups, putting pressure on the Department of Health to deregulate or to make them prescription free?
As part of my role in the XGP, I liaise with the HSE naloxone leads, so we would push for that. But I guess
to me, though, that sounds like I don't mean it in a pejorative way, but that's upholding a system that is incorrect. And I'm just wondering, from an outside point of view, is there engagement saying, actually, working around a bad law is fine, we'll do that for now, but the law should be changed?
So from the perspective, and again speaking as the chair of the Naloxone Advisory Group, yes, there is pressure being put on the Department of Health to have a look at changing that legislation to allow this product to be available without prescription.